Now we're going to talk about contraception, and our objectives are these: to understand the factors that influence contraceptive use, to understand the various methods of contraception, and to be able to make an assessment of which methods would be inappropriate for which clients. In other words, which ones are contraindicated. Factors that influence the contraceptive use, the method the woman selects, is mostly its effectiveness. Which ones are going to most likely protect against pregnancy, and is it an acceptable method to the client? Some women are fine with the postcoital method of birth control. Others consider that an abortive type method, so would not want to use that. So we need to understand our clients and what their acceptance level is for different methods. What do they know about the contraception? Do they have the ability to understand, for example, the birth control pill and how to take it properly, or are they going to miss pills and not know what to do? In patients like that, it might be better to do a method that they don't have to remember to take every day. We have Norplant, we have progesterone shots, different methods that do not require them to have daily remembrance to take it. Well, how convenient is the method? If it's a complicated method, they're not going to do it. What are the beneficial side effects? Some women don't even consider that, but some of these methods have a side effect that is actually beneficial. For example, being on the birth control pill may straighten out some of the abnormal in-between irregular bleeding a woman has, and it may also decrease menstrual cramps. So that could be a reason for starting the pill. How spontaneous is the person with her partner? Do they have to plan ahead, or are they able to, well, basically, are they able to plan ahead and prepare? How available is the contraceptive method? Where are the local clinics? What is their insurance? What is the most easily obtained? Cost of it, of course, is very important. If it's too expensive, people aren't going to use it. And then again, the religious and personal beliefs, as I mentioned with the post-coital abortifacients, are they going to accept those or not? And a lot of religious beliefs do not allow for that. What is their culture? Certain cultures don't believe in birth control, believe it or not. We have to understand what those cultures are and counsel the woman on how to minimize pregnancy rates. And what are their future pregnancy plans? Are they done having babies? If they know for 100% sure they're done, they may elect to do a permanent method, such as sterilization. If they're not sure, we don't want to do a permanent method. We want to keep that option open for them until they're 100% sure. Birth control pills have been the leading birth control method since 1982. It is the most widely used method for women in their teens and 20s, for women who have never been married, and for women with at least a college degree. So a lot of planning goes into taking the pill. You have to remember to pick them up. You have to remember to take them every day, and you have to know what to do if you do miss one. Sterilization is the most common method for women who are greater than 35 years of age. It is the leading method for Black and Hispanic patients, and women who are currently or previously married, and women with less than a college education will elect sterilization over some of the other methods. Get it done. You don't have to ever think about it again. Interestingly, the proportion of people who use a birth control method the first time they have intercourse in the 1970s was 43%. In about the year 2000, the rate was 79% who used a method. So we've made a lot of improvements in that area of awareness and knowing how to prepare and being prepared. Condoms are the most common method used. The age and use of first time before 18 years old, 55% of them used a method. Those that are 19 or older, 75% used a method. So you tend to get a little smarter as you get a little older, it looks like. The non-Hispanic white women, 60% of them would use birth control that first time. Black women, it's 60%, and Hispanic women, it's 46%. Choosing a method requires a good talk with the patient and her partner, perhaps, about different angles to look at. And family and personal health history. Are they able to take a hormone method, or do they have a health history that prevents them from taking hormones? What is the effectiveness rate they need? Do they want as close to 100% as possible, or are they willing to accept a pregnancy if it happened in the less effective methods? How often do they have intercourse? That's going to influence the method they choose. Someone who has intercourse frequently is probably not going to want to use diaphragm, because that has to be put in prior to each time they have intercourse, so it may not be the method that's perfect for them. Someone who has sex once a month, why be on the pill the whole month if you can use a diaphragm and condoms? So knowing this information is important. The cost of the method, IUDs are very expensive initially, but they last for up to 10 years. So overall, the cost could be quite affordable compared to other methods. How able are they to keep contraceptive supplies on hand? That may be an age factor. You have a young girl whose mom doesn't know she's getting the birth control pill. Can she easily go get more pills? Because it's not required for teenagers to tell their mom that they're going to be on the pill. They're allowed to do that. Strength of motivation to use a method is important. If they have to put in a diaphragm every time and they're not motivated to do it, they're not going to do it. They're going to get pregnant. So if they want to just have a method and forget about it, IUD might be the way to go. And what is the risk of transmitting or getting a sexually transmitted disease? And I mentioned the IUD. In someone who has multiple sex partners, the IUD is not going to be a good choice because that increases their risk of getting infection in the uterus. The IUD is implanted in the uterus, and it has a little string that is protruding from the cervical os. And if they have multiple sex partners, that increases their risk of infection being introduced into the vaginal area and then transmitting up into the uterus, and they'll have severe infections. Natural methods or rhythm methods are very inexpensive, but you sure have to pay attention. There's no drugs or hormones involved. It can be combined with barrier methods such as the condoms or diaphragm and condoms to increase the effectiveness. And it is acceptable in most religions because it's not it's preventing pregnancy, pure and simple. It is not terminating one that might have happened. Different types of natural methods involve the calendar method, and that requires a patient to prepare by keeping track of when she has periods for about 3 months. And using those 3 months as a baseline, we would help her calculate when is her most likely time during the month to have ovulation, and she would avoid intercourse during those 3 or 4 or 5 days, knowing that the other days she should be safe. Basal body thermometer method, that's where they take their temperature every day. If they have to be very, very vigilant about this, take the temperature before they get out of bed, chart it, document it, watch for the increase and drop, which is when they're ovulating, and avoid intercourse on those days. The cervical mucus, which at the time of fertility, a woman's cervical mucus will thin out and get stringier, and that's to allow the sperm a better ability to go up into the uterus and get her pregnant. So if there's thick mucus, then they are safe, and if the mucus is thinning out, probably best to not have intercourse. Symptothermal method is a combination of the calendar method and taking their temperature. It's going to be a little more effective. The best method, most effective method for not getting pregnant is abstinence. However, is that realistic? It depends on your patient. We need to include that, though, as a method because it is a very legitimate method of birth control. Withdrawal, it has a failure rate of about 27%. There is semen in that pre-ejaculate, which can get the woman pregnant. So withdrawal is not considered an effective method of birth control. A quarter of the time they're going to get pregnant. Have sex 4 times, you're going to get pregnant once. Breastfeeding, I call this the OB physician's car payment plan, because some will tell women they can't get pregnant when they're breastfeeding, and it's not true. Breastfeeding does tend to inhibit ovulation because suckling and prolactin interfere with that releasing hormone that allows the egg to release. However, it's very dependent on the frequency that they breastfeed. If they're not breastfeeding frequently, then it's not going to work. They're going to ovulate. Breastfeeding is not a very effective birth control method for most women. Hormonal methods are prescriptive methods, birth control pills and progesterone-only pills, and there are also hormonal method called the progesterone shot, Depo-Provera being a generic, or the brand name. Hormonal methods do not protect from sexually transmitted diseases because there's no barrier there. So someone who is saying, well, I can't get pregnant when I'm on the pill, that is correct, but you can still get STDs, and those can often be more harmful than a pregnancy. There are two basic types of hormonal methods. One is the combined estrogen and progesterone pill. Those are the most common ones. They provide a hormonal base that when the levels change and drop, the woman will have her period, and then she starts the pill again. She's on a hormone 3 weeks of the month and 1 week off, or they take a placebo pill that week. So they're taking a pill every single day for 4 weeks, but 7 of those days are just placebo sugar pills, tiny little pills. Reminder to take them. The progestin-only pills are referred to as the mini pill, and those are safe to take when a woman is breastfeeding, and they will increase the contraceptive rate, effectiveness rate of breastfeeding moms if they're also taking a mini pill or getting progesterone shots, the Depo-Provera. Progesterone-only pills, every pill's the same. They have to be taken every single day. There's no week off. So what happens is their periods will be irregular. And some women do not like that. Others are fine with it. You just have to let the woman try it and see if she's okay with it or not. Whether they take combined pills or progesterone-only pills, they need to be on them for at least 3 months to see how their body is going to react to it. What regularity will they have before you make any changes to their pills? So they need to be told that it takes about 3 months for your hormonal system in your body to get used to this. So let's see what happens after 3 months. The method of action for birth control pills is it prevents pregnancy by preventing ovulation. And it also changes that cervical mucus thickens it up a bit, so it prevents the sperm from being able to move up. And then it also alters the uterine environment, the lining of the uterus, so that products of conceptions, that's what POCs are, that cannot implant. So a little bit might be considered an abortive method for purists in that area, because these egg and sperm may meet up, but they just can't implant. Contraindications of using the combined birth control pill are women with a history of blood clots. It does increase the clotting factors. If they've had a CVA, strokes, cardiac problems, breast or estrogen-related cancers are a contraindication, because the estrogen in the pill can cause an increase in the estrogen-related cancer. And women who are over 35 years of age and smoke. And it's very vital that they get off a hormone method if they're a smoker after the age of 35, because their risk of blood clots and strokes really starts to climb. The effectiveness of hormonal methods, birth control pills basically, is less when taking certain medications. So meds that affect the liver enzymes, such as anticonvulsants and some antibiotics, they may decrease the effectiveness of the birth control pill, and the woman could get pregnant. We tell them in those cases to use, if they're on antibiotics, let's say, for 10 days or so, to use condoms as well during that time that they're on the antibiotic, just to prevent that. The combined pills have both estrogen and progestin in them, and most of the newer formulations contain a very low dose of ethinyl estradiol. they started out with birth control pills, the estrogen being 100 micrograms. Woo! When I look back at that now, it's amazing we didn't all die from them. I wasn't, it was before my time, but very high micrograms. But over the years and over time, with more and more tests and trials, they've gotten it down to 35 mics is a pretty normal dose, and some of them even go as low as 20 micrograms. And then there's 8 different progestins. And you're like, how do we determine which pill a woman would be on? How does your doctor know which pill to order for you? It's basically trial and error. That's all it is. We do have things that we look at to determine when the bleeding is happening, what might be better, but really it's try and see. That's what it is. Progesterone-only pills, called a mini pill, they are appropriate, as I said, for breastfeeding moms or women who are at the increased risk of stroke. It doesn't have the estrogen in them, so they can take these. They are a little bit less effective than the combined oral contraceptives, but it's still pretty effective. There are 2 types of progestins. There's norethindrone and norgestrel. Again, trial and error. Which one does each person respond to best? These, again, you never off for a week. Every pill is a progesterone pill. The hormone patches hit the market several decades ago, well, a couple anyway. They have synthetic estrogen and progesterone in them, and this is the patch put on the skin once a week for 3 weeks, and that delivers over that 3 weeks. The estrogen and progesterone is absorbed through the skin, and then they take the patch off, and that should allow the body to have a period, and then they put the patch on again after being off of it a week. It is less effective in the women who are about 200 pounds because of the amount of fat that they have. The estrogen can be taken up in that fat, and so instead of preventing pregnancy, it's just hanging out in the fat because fat loves estrogen. Emergency contraceptive, the morning after pill, the postcoital hormone method is called Plan B as well, and this prevents pregnancy after unprotected coitus. You know, it's better to plan ahead, but if there's been a time when different situations might result in the need for this. So, and again, it is definitely considered an abortion type method, so patients need to be aware that that is considered that type of a method, so they stay within their own belief system. Depo-Provera, this is the progesterone-only method that's given by injection. Depo-Provera, you don't need to know these specific types of Depo-Provera and progesterones, but just know that this shot is given 4 times a year or every 12 weeks. And it's important that the patient either remembers to come in every 12 weeks or the office sends her a reminder every 10 weeks so that she has a couple weeks to get in. These are given in IM, and I always gave them in the gluteal butt muscle back there because I don't like giving arm shots. Vaginal ring, it's a NuvaRing is what it's called. It's a hormonal method where the hormone is absorbed directly into the vaginal tissue. It releases synthetic estrogens and progesterones and prevents ovulation as well. And it's placed in the vagina 3 weeks each month. So it's put in 3 weeks, taken out, get a period, and then put another one in. Norplant is, and now they're down to, I think it's just maybe 1 or only 2 rods now. When I was inserting them, they had the 5, a little fan shape. They are flexible and implantable, and they contain progesterone, and they're effective for up to 3 years. They need to be placed very superficially. Ideally, you'd be able to palpate them. This one is really superficial. It should be a little deeper than that, but they need to be palpable so you can feel the number of rods in there. If they're implanted too deeply, 3 years goes by, it is really hard to get them out. So proper insertion is essential to having it be a non-complicated method. The IUD, it has undergone several transformations over the years. It is now, there's 2 types. It's a small T-shaped contraceptive device which is placed in the uterus. There's the copper T and then the Progestisert. They are inserted looking like a clothespin, and once it goes in, bing, it pings open so that the T part holds the IUD inside the uterus. It's best if it's put in while the woman is on her period, because then she's already bleeding then, so she won't notice any extra bleeding from the IUD insertion. Plus, that cervical opening is open a little bit, and so it's easier to place in a woman who's on her period for that reason. It is available by prescription only, is inserted in the office. The copper T contains copper and can be left in place for 10 years. Then the Progestin is an annually replaced one. It's progesterone only. And then, as I mentioned earlier, it has a high initial cost, but over 10 years, it becomes very cost effective. Which women would you think would not be good candidates for the IUD? We already talked about them. The ones that have more than one sex partner at higher risk of endometritis, uterine infections. Here's a good picture. These are the T's. Let's see, this is the copper one, and this is the progesterone one. They start out, these little flanges that you see here are actually held, they're down like that. So it's basically a tube with these down like that. And once it's inserted, these ping open and become a T. And it's just in there. What it does is it acts hormonally. The progesterone ones act hormonally to change the environment of the uterus so they can't implant. So it is considered a post-abortive, a post-ovulation method. So women who do not believe in abortion at any level would not want an IUD. The copper 7, and both of them do this, it acts to kind of irritate the uterine lining, and that's not a very good word because it's not really irritated, but again, it just makes that uterine lining not amenable to implantation. It's important for women who have an IUD to be taught how to check that the string is still in place every month after their period is over, because there's a risk of the IUDs just falling out with the period blood especially if they have heavy periods. So they need to be taught how to feel that the string is still in place. Contraindications for IUDs, as I've mentioned now several times, women who are not in a monogamous relationship. Now, nullips, I put a question mark. A nullip is someone who's never been pregnant. So their ability to have that IUD inserted may be a little more difficult, but it's not definitely contraindicated. Someone who's never had a baby can still have an IUD put in. It may cause irregular periods. That's one of the reasons some women will not like it, because their periods become irregular. Some women, it cures their periods, actually. It can go the other way. Women who have a history of pelvic inflammatory disease, PID, because they are already had an infection in the uterus at some time previously, so we don't want to introduce something in the uterus that can get infected again. HIV positive women, of course, because of the decrease in their immune system. History of ectopic pregnancies. If they're had a problem before where the egg just got stuck in the tube and got fertilized in the tube, we would not want them to have an IUD, because they can end up again with infection, inflammation, and scar tissue, which causes that to be more possible. So that's the risk with the uterine and ovarian tubal infections, is scar tissue that's formed and causes a place for a pregnancy to just stick, grow, and hurt, cause problems. Ectopic pregnancies can kill a patient very quickly because they can burst and bleed out. Wilson's disease, which is just some guy named Wilson decided to call it after himself, but that's where they cannot metabolize the copper. So the copper IUD would be contraindicated for those patients. Sure, I'm not going to even try to play this video. We'll do it in class. Non-hormonal barrier methods, they do offer some protection from STDs, because if they're preventing sperm from going up in there, they're also providing some protection from bacteria going up in there. They are, they're the most coitus related. In other words, you have to plan ahead. You have to have condoms ready. You have to have your diaphragm handy. You know, if you have not the NuvaRing because that goes in, but if you have a cervical cap, that has to be ready for use prior to having intercourse. So you have to be able to plan ahead. It may interfere with sensation during the active intercourse. That's not a common problem, but it may. Sometimes the guys will say that they can't feel the same. Oh well. Oh well. And they're contraindicated if the patient is allergic to components of the method or the latex, or if their partner is allergic. The male condom is one that you're most likely have heard of. It's sheaths of thin latex or plastic that's worn on the penis during intercourse, and it's available either dry or lubricated. It needs to be removed quickly after intercourse and held. The man has to hold it when he pulls it out so that it doesn't stay inside the woman and get her pregnant. Then there's the female condom. And that's where the woman puts, you can see here, it's a condom that she puts inside and the man's just going into her condom. Okay. Spermacides, well, it's better than nothing, but not much. It is very reversible. You just stop using it. It's available as a foam, a cream, jelly, film, suppository. It's a chemical which immobilizes the sperm. Basically, it kills their sperm killers. It prevents the ability of that sperm to meet up and join with the egg. So spermicides are, I'm going to say 60% effective, I think. But if the patient uses spermicide and her partner uses condoms, she's up to 98% protected. So they're pretty good used together with condoms, but used alone, better than a lot of other things, but not so good overall. The diaphragm is a shallow dome-shaped cup with a flexible rim. It's made of latex. The woman needs to be fitted for the proper size during an office visit. She needs to be taught how to put it in and how to take it out. That needs to be put in within 2 hours of having intercourse. The diaphragm itself is covered, it's used with a diaphragm jelly, contraceptive jelly, and no, it's not jelly. It is a contraceptive type gel that goes around the whole rim of the diaphragm and then glop some in the center of it and mix it around in there so that her cervix is basically sitting in a pool of contraceptive jelly that's going to kill sperm that sneak past the diaphragm rim. Then it has to stay in place for 6 to 8 hours afterwards so that she doesn't remove her contraceptive killers. We want it to stay there until the sperm have had time to be rendered unable to do any damage. Okay, so it's got to stay in 6 to 8 hours and then take it out, and we teach them to clean it. It's real simple. And if they gain or lose a lot of weight, then they need to be refitted for their diaphragm, because weight change of large amounts, 30, 40 pounds, can change the shape and size of the vaginal opening. So yes, they need to be refitted with they're on a weight loss program. Or if they gain a lot, it's going to get uncomfortable. This is the contraceptive jelly here, one of the many types, Vaginal 2. And what we teach the woman to do, this is sitting upside down. If you flipped it over, what you would be seeing would be the part where the cervix sits in. So flipping this over, you would put contraceptive jelly all around the rim, the underside of this, and then a glob in the middle and smear it around with your finger. So that's, and then we teach the woman how to bend it in half like that, slide it in, and then check and feel that she feels the cervix covered, that the diaphragm is covering that cervix. And it can be kind of awkward, but you know, if you have a good attitude and a good humor, I always stayed in the room when my patients put them in the first time, because they would have questions, and rather than have them sitting in there worried about when I was going to return, I thought, we'll just stay in here and make sure we can get this done. And I never had any woman have a problem with that. And yes, we did do a lot of laughing, and that's okay. The cervical cap was also mentioned as a barrier method. It's similar to the diaphragm, but smaller. It's held in place mainly by suction, and it also requires spermicide, but not as much. This can be inserted 8 hours before intercourse, so it does allow some additional spontaneity, and it can stay in place for a couple days. There's no pressure against the bladder with the cervical cap, because it literally just fits on the cervix. It's not held in place by the vaginal wall like the diaphragm is. It is initially expensive, but then of course the more you use it, the less expensive it is per use. Contraindications to the cervical cap, or mainly the cervical cap, is the history of toxic shock syndrome. If they have had a previously abnormal pap smear result, we don't want to have their cervix sitting inside that contraceptive jelly, which is an abnormal hormonal environment. If they have an allergy to latex or spermicide, of course. If they have a history of pelvic inflammatory disease, cervical cancer would certainly be a contraindication. Undiagnosed vaginal bleeding, for one thing, we need to figure out what's going on. So we don't want to just give them a method that may be exacerbated by the use of, or made worse by the use of a cervical cap. And if they have, this has gone through many names throughout the years, papillomavirus, condylomata, genital warts, they're all the same. But if they have genital warts, we don't want them using these methods either. The Today Sponge, I don't even know if these are still on the market. So the Today Sponge is the not natural. And then you add, yes, we do have this natural sponge stuff over here. The Today Sponge is a polyurethane foam, and it contains spermicide. It covers the cervix and blocks the sperm. It went through a period of time where they had a lot of toxic shock from these. So that's why I don't know if they're still on the market. I'm going to have to check. Then you have these sponges, which have varying levels of effectiveness because they are truly sponges right from the ocean. Yes, they are. Permanent methods, of course, there's two types. Tie her tubes or tie his tubes. Either she gets a bilateral tubal ligation or he'll get a vasectomy. Female bilateral tubal ligation is effective immediately because once the tubes are tied, the egg can't get through. At vasectomy, it takes a couple months, 2 to 3 months, for the vasectomy to be determined to be completely ready to rely on, because the sperm will still contain, the semen will still contain sperm for several ejaculations. So the men have to go back and have a recheck to see when they are finally considered infertile after a vasectomy. Don't rely on that one right away. You'll get pregnant. Contraindications with the tubals, with those permanent methods, are if they are not sure, if there's any doubt about whether or not they want to have children again, if the relationship is rocky and she or he may be getting divorced, they might want children with another partner in the future. Do not do permanent methods. There are other very effective non-permanent methods they can use. This is just a comparison chart of the effectiveness of the different methods. Sterilization, as you can see, is the most effective. And down there at the bottom is not using contraception at all. 85% of the time you're going to get pregnant. And then you have the varying degrees along the way. So you can just kind of look and see if you are personally on a birth control method. You can see what your percentage of effectiveness rate is. Natural family planning, 25%. It depends, if you're okay with another baby, that would be a great method to use. And kind of like for someone who's a religious person, we'll let God decide. We'll do what we can, but not worry about it, kind of a thing. Someone who is a teenager and definitely doesn't want to get pregnant, of course, we're not going to sterilize them. We're not going to put an IUD in them because of the risk of infection. But perhaps they could do these oral contraceptives. Pretty effective, 88%. Okay, so it's just a matter of talking with your patient, understanding her risk factors for different methods, and then helping her come to a decision that is acceptable to her and safe. And that's it.